and thank you for inviting me to give this talk. Next slide. Yeah. Right, so these are my disclosures. Yeah, usual. Where should I point to? Yes, yeah, okay. So just a brief overview where I come from or where I work. So it's a Queen Elizabeth Hospital in Birmingham. It's a large tertiary center. We cover approximately 4.5 million population, roughly 6,000 to 7,000 patients with MS, although it's fair to say we haven't got a proper database to say that. Hopefully we'll have it at some point in the future. We have around 2,000 patients on various DMTs, and we cover a very large area from down to Hereford and then up Wolverhampton and Tamworth and Lichfield, so it's a fair stretch. Currently, we have 4 consultants, which is absolutely amazing because up until, say, 3 years ago, we had just 2, John and I, and it was obviously very busy. I can't say it's less busy now. And then nurses, again, we're going to be appointing another nurse recently. There are 14 around 14 district general nurses. We have a MS coordinator, which is absolutely essential, so I strongly recommend you get yourself one if you can. And then I have a research fellow as well. So this is our team, this is our hospital, and this is my favorite slide, I think. You probably can recognize Sam and Sharon here somewhere hiding. Anyway, so presentation. So any Latin speakers, any native Latin speakers, apart from Neil? Yeah, Anyway, it comes in threes, so they're my first 3 cases. So this is a patient who was born in 1980, so he was 34 at the time of his presentation. And this is his relapse history, and you can see you would clearly define him as a rapidly evolving severe RRMS. So he relapsed first in February 2010, then in July, then in January, then around Easter, and then in June. And he was, when I saw him, he was also relapsing. So his previous scan, he was seen privately, and then he was sent to us, to the QE. And this was his original scan. And somewhere in my letter, I said that I counted more than 10 post-contrast enhancing lesions, and if you see, this is a T1 sequence, cuts bottom and then top, and you can see it's a fair number of post-contrast enhancing lesions, and his MRI scan of the spinal cord, and as you can see here, maybe I'm not sure whether you can appreciate, there's an area of enhancement. I think that's C6 or thereabouts. So I saw him in June 2011. He, on examination, had a non-sustained nystagmus on lateral gaze, double vision on lateral gaze, and he was weak in the upper legs in pyramidal fashion, and he was unsteady, so had some cerebellar signs as well. So I calculated his EDSS score at the time at 3.5. And we agreed to start him on Tysabri, which he commenced in August 2011. He was JC virus positive. And then this is an extract from his MRI scan report from October 2012. So some 15 months after he was given Tysabri. And I say here, or the radiologists say, that there has been a significant improvement of the white matter lesions. No abnormality in the spinal cord, which is very interesting. So we cured him radiologically in terms of the spinal cord, and no evidence of enhancement to suggest active disease at the time of the scan. So in August 2013, his EDSS was 0, so from 3.5 to 0, although he was relapsing at the time when I scored his EDSS. So we would expect some natural recovery to occur within 3 to 6 months. And then around, beginning of 2014, we were able to measure JC virus index. And his index was high at 385. And this is a letter Sharon wrote to him saying that there is a suggestion of checking how high the antibodies for JC virus are, can help define individual risks. So he was somewhere around here. So 1 in 123 chance of developing PML. So in August we met and he decided, so within 4 months or something, to change or to de-escalate to fingolimod. So, and he had a scan in 2014, August time. At this point he was completely asymptomatic. So just a question to the audience, can you see anything abnormal on the scan or not? Anybody? Apart from David and Neil. Can you see anything abnormal? Okay, so if you stand back in particular, I can see that there is a little bit of whiteness here and here. And then here, that's not quite normal, it's not symmetrical, although he was slightly tilted to one side. So it's an abnormal scan. It wasn't reported like that, just to tell you that. In September, he had CSF examination, and at that point he was asymptomatic, or we think he was asymptomatic. And then within a week, he reported his symptoms. So, and this is his MRI scan, which was done on the same day when I saw him in clinic. And as you can see, there are obvious changes from the bottom to the top of the brain. So these hazy areas of signal change, cortically, subcortically, but also in the area of basal ganglia, and then pons as well here. On the left side. So that's the December scan, and obviously this was my first case of PML, and he was literally getting worse, every day. And we tried various things, and I will show you the slide on that, but nothing worked. So by December, I think Christmas time, he was in what we call myoclonic status epilepticus. So he was jerking all the time despite being loaded with various anti-epileptic drugs. Surface EEG was normal, which was interesting. So abnormal electrical activity was coming from the basal ganglia, presumably. And at this stage, he was transferred to ITU, put to sleep, and he spent his Christmas, asleep. Then, in terms of treatment, so this was the poster presentation I used to treat him. So he received plasma exchange. He was given mirtazapine and mefloquine, and allegedly these two drugs compete with the entrance of the virus with a receptor which enables the virus to enter the nerve cell. He was given cidofovir. There are a few case reports of patients with HIV responding to cidofovir, no real evidence. I also gave him granulocyte colony stimulating factor to increase his lymphocyte population. So his, if I remember correctly, his neutrophil count went up to 48 and his lymphocyte count went up to 8. He had 2 minor episodes which I would classify as iris with some some contrast enhancement on his scan, but we gave him steroids just for I think 2 or 3 days. But despite all that, he ended up on ITU. Now he turned his corner February, March time, and this is his follow-up MRI scan from December. 2015, you can see a devastating effect of that widespread, severe, destructive JC virus-related inflammation. So it's a kind of walnut-looking brain, and there's a severe atrophy in the affected areas, so temporal, parietal, with some areas of signal change. I mean, what I think maybe you missed that, but his JC virus CSF count, a viral load was only 33 per 1 ml of CSF fluid, so very low, which is not quite in keeping what we saw on the scan. You would expect much higher viral load in the CSF. So I saw him in July formally, so at that point his examination didn't really change over the years. He had visual agnosia, so that is because of involvement of the occipital lobe, so he cannot recognize what is in front of him. That's called Anton syndrome, I think. And he had dense right-sided hemiparesis in a typical pyramidal distribution. He was able to walk with a stick, say 20 to 50 meters. So his EDSS score was 6. He has not relapsed since he had PML, which is quite interesting. And unfortunately, and that's the main problem for him now, he has intermittent, often very prolonged partial motor seizures with a often very violent twitching on the right side, secondary to cortical and subcortical damage on the opposite side of the brain, despite being on free anti-epileptic drugs. So that's the first case. Now the second case. This gentleman was born in 1959. He was stable. I'm not going to go into a great detail of his history, but just you can see the different radiological presentation of PML. So effectively, he had a scan in June, which was absolutely fine. He was stable clinically and radiologically, no any evidence of PML. He had some family issues during summer. His mother was ill and passed away. Eventually, he was a bit depressed. He was always depressed, but a bit more than usually at that time. And then towards the end of summer, he started complaining about being off balance, which then progressed. And his MRI scan showed these monsters in the frontal and parietal lobes. His JC virus index, 900,000 copies per mil, you can say. So massive viral load per mil. His JC virus index, JCV index jumped from 0.74 to 2.3. So he changed converted within a few months. And then my third case. So this lady was on Tysabri for 6 years. Prior to that, she was on Copaxone, which she failed. She was JC virus positive, and her index was always below 1. And this is the risk we gave her at that time. November scan, stable, and then she presented in January 2017 with progressive speech disturbance, and you can see in the appropriate area on the left side there is a signal change, which is cortical and subcortical. And the JC virus load was relatively low again, 192. So, the previous patient, he's bedbound in a nursing home. I haven't seen him for the past 2 years, so very, very poor outcome. Alive, though. She was actually fine until May of last year, when she had she didn't want to be treated to start with, and she had a disabling spinal relapse with leg weakness and difficulty walking, and you can see fairly a large and extensive area of signal change, inflammatory signal change in the upper neck, which enhanced post-contrast. I saw her in December. Her EDSS was 3.5. In the meantime, between May and December, she tried Rebif and Copaxone, but she couldn't tolerate them really, and we are going to start on the Aubagio. We discussed Ocrevus and Lemtrada, but I think none of us is confident to say what will happen to an ex-PML patient if you give an immunosuppressive treatment of that type. Obviously, there are cases of, not often, but cases of PML with rituximab, and as you know, one case of PML with Ocrevus. We have no idea what will happen to her if you give her Lemtrada and kill her all T and B cells. So we were not very confident to use that one, and she didn't want it either. So just a short reminder, I think David will be talking about that in more details. This is a communication from Biogen from December. So far, 822 cases in MS, 24% mortality. So that has not changed significantly. Okay, so bad if you do, bad if you don't. So just on the flip side of the whole Tysabri argument. So this young lady who was 27 at the time, she was started on Tysabri in 2012, and then she decided to stop Tysabri in April 2014 after becoming JC virus positive. And then, surprise, surprise, presented in August 2014 with a multifocal relapse. I think she was transferred from her local district general hospital to us, and she was essentially encephalopathic, confused, disorientated, sawn off. You can see there is a large inflammatory area in the spinal cord in the neck. And I think we calculated in excess of 50 post-contrast enhancing lesions. So clear rebound disease following after Tysabri was stopped. So, and then another case, this time secondary progressive multiple sclerosis. So this lady was part of our ASCEND trial, which was negative. So we stopped the trial because we couldn't obviously continue with Tysabri. And then she had two very disabling relapses, especially that one in March. And this is an abstract from her MRI scan report. Lesions on the left side of the pons and middle cerebral peduncle. So we treated her with steroids. I think she relapsed after that one more time. And I'm almost certain that we have accelerated her decline. And I think she sadly died 12 or 18 months after this. Now, is there any evidence to suggest that withdrawing Tysabri treatment can do that? And yes, there is. I'll just single out this paper. They call it immune reconstruction. So it's essentially IRIS after withdrawing Tysabri. So a small number of patients. Nevertheless, if you look at the number of post-contrast enhancing lesions after Tysabri was stopped, you know, from none to quite a few, and disease would come back from 2 to 4 months after Tysabri was stopped. If you look at this table here, that's in days. Okay, so next, yeah. So what happens if you discontinue against a small number of patients? But if you stop first-line treatment, you can expect that the disease of patients will relapse, or proportion of patients with relapse, although in those who are over 55, that should not really add to their neurological disability. There's good evidence that if you're younger, i.e. less than 55, relapses in SPMS do contribute to accumulation of neurological disability. So, and again, small number of patients, you can interpret that in various ways. But up to 1/3 of patients developed essentially rebound disease. So that's something we need to be careful about when we stop treatments like Tysabri. Okay, moving on. A case of swollen brain. So all weird and not so wonderful, I would say. So this lady was treated. I mean, this is abstract. We present poster presentation. We presented somewhere. So in her 40s, essentially a 7-year history of RRMS, hyperthyroid, nothing else, and then 3-day history. That was essentially from Wednesday to Friday. Progressive confusion, severe sensory motor dysphasia, and right-sided hemiparesis. In terms of her DMT history, she was on Avonex for 3 years and then relapsed, so we escalated her to fingolimod, and within 2 or 3 months she developed this over a 3-day period, and essentially it's not a tumor, it's a case of tumefactive MS, so it's a very severe inflammatory reaction to, we presume, fingolimod. We tested in the CSF as well and in blood various cytokines, and there was no obvious clue to tell us why this happened. I think we even attempted to send her frozen blood to San Francisco clinic, but it didn't work for some reason. Anyway, she's done well. She was given loads of steroids and plasma exchange, and then given Tysabri, and she's now actually fine. So she had mild speech problems and I think weakness in one leg, walks normally. So, and subsequent scans were absolutely fine. So this is all settled. Now a case of rebound disease, a funny one. This gentleman presented in September 2014 with left-sided sensory disturbance and then weakness in the left arm, and he was unsteady. And shortly after that, he relapsed again, and he was given Avonex, but then in June 2015 had a multifocal relapse, and his MRI scan showed effectively tumefactive inflammation. He was given again steroids, plasma exchange, and he was commenced on Lemtrada in July 2015 as an inpatient. And then 10 months after that, effectively this is again poster presentation from somewhere, he developed tumefactive, worsening of tumefactive disease, and you can see a large area of signal change in pons. And again, I think he spent his 19th or 20th birthday on ITU. He wasn't breathing for 3 days, literally. But then again, with lots of steroids and plasma exchange. And eventually we gave him cyclophosphamide as a rescue therapy. He had 6 courses, and actually he walked out, which is quite amazing. Now, he could not decide which treatment to start. We offered him a referral for stem cell treatment, which he declined. He was very briefly on fingolimod, which didn't work. And then eventually in 2019, he was given cladribine. He had a couple of relatively minor brainstem relapses in between. Okay, and then somebody who responded well to Lemtrada. I think there's nothing much to talk about this one. So somebody who had 2 severe multifocal disabling relapses within 6 months of his presentation, given first Lemtrada in January. That was his pre-Lemtrada scan, and you can see there is evidence of call these T1 black holes, which indicate severe damage to the brain, secondary to inflammation. And then this is his subsequent scan looks much better, and he is stable. His EDSS is 1, so he's done well. Right, this isn't my case, but I think it's very instructive actually. First case of this kind, so I may ask David and Neil to give us an answer. This is a 27-year-old Finnish lady who moved to the UK, I think in 2018. So she was diagnosed age 12. She was, pediatric MS, she was first given Avonex, and then she failed that, and then she was given Tysabri. Then she became JC, that was all in Finland, okay, up to here. She was then de-escalated to Copaxone, which she failed, and then given Fingolimod, which she failed, and then Ocrevus. Now, she had radiological evidence of radiological activity on Ocrevus. She had radiological activity on Fingolimod, and that's why she was escalated to Ocrevus in Finland. And then at that point, I think we were not ready to give Ocrevus, and then she was going to be given Fingolimod, but that was delayed because she didn't have a GP and the usual technical and eligibility issues. And then she had 2 very severe and very disabling relapses with very, very active-looking scan with spinal cord lesions, severe weakness in the legs. She was practically unable to walk. And then we decided to give her alemtuzumab. Obviously, she was given steroids and plasma exchange. And we decided to give her alemtuzumab, which was at the beginning, 11th of January last year. So then she was discharged on the 14th, so a few days after. But then she reported just not feeling very well and reported weakness in the legs and more difficulty walking a week after that or thereabout. And this was considered to be another relapse. And she was given a course of steroids and wasn't really picking up very well. She was screened for infection, no evidence of urinary tract infection. Chest was fine. She wasn't really pyrexial. Inflammatory markers were not raised, but she was tachycardic, and the physio, they were complaining that they couldn't do any physio with her because she would just, she would be tachycardic and she couldn't kind of tolerate any exercise. And then a couple of days after that heart rate issue, she developed pyrexia. Any suggestions, any comments? No?
She's infected until prone otherwise.
Okay, so that's a good guess, very good. Was this in some sort of infection? She was started on a broad-spectrum antibiotic. Systemic examination was normal blood cultures, urine culture, heart was okay, chest X-ray, ultrasound, CT, everything was okay. And CSF didn't really show anything. There was no evidence of any meningitis or any viral infection. There was something in the CSF, I won't tell you. Okay, and then more tests, blah, 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 and everything was really negative. But then we have performed a diagnostic test. We were thinking about whether this is a central cause. I had one patient with hypothalamic lesion, and she would just drop her temperature to 31 every time she had urinary tract infection because of that hypothalamic lesion. So we were thinking about the central cause at the time. But then, as I said, diagnostic test was performed. Okay, hi. So this is against, at that point, she had high CRP levels, and there was no evidence of hypothalamic involvement in her particular case. So it wasn't central, really. Right, so we done the cytomegalovirus test, and she had millions in the blood. So She was given ganciclovir, obviously levels dropped, and essentially this was a case of cytomegalovirus viremia without any organ damage. So, and yes, it was reported, and oops, and these are the papers. I think one more, yeah. So that's all I have to say, and you're welcome to ask me any questions.